Thank you, Dan. All right, now it is my pleasure to actually introduce Rachel Gordesky, who I've only had the pleasure of meeting today, and she's also in Chicago, so I hope to get to know her much more in the coming years. She's the newly appointed residency program director at Loyola Pathology, but she's not new to Chicago. She received her medical degree in Wayne State and then came to Chicago to complete her APCP residency at the University of Illinois. She then went on to do a cytopathology and a surgical pathology fellowship with a focus on breast and GU at GW. I was at GW too for my residency and Surg Path fellowship. And then in 2019, she began to work as an assistant professor of pathology at Howard University in DC, where she was also the director of second year medical students course. And now in Loyola, she will be in charge of the residents and also continue medical students. So welcome, Rachel.
So thank you so much. I am going to take us through the work of Dr. James Wright, Cytopathology, Why Did It Take So Long to Thrive? So we have no disclosures. So as I said, we'll discuss Dr. James Wright's work. We'll start with a brief overview of the development of cytopathology, and then discuss early cytopathology with a focus on Lionel Beale and Leonard Dudgeon. And we'll discuss why there was a 60-year plus gap between their works. We'll talk a little bit about George Papanicolaou and Earl Babish's initial work in the late 1920s, and why they continue to have a lack of impact. And then why there was another 20-year gap before Papanicolaou and Trout's seminal work in the 1940s. So starting with Lionel Beale, he is regarded as the father of clinical pathology and a founder of cancer cytopathology. He wrote many influential textbooks on microscopy, where he classified cells by shape along with what part of the body they came from. He was also able to describe cancerous changes and how those differed from benign changes. He advocated for the microscopic examination of vaginal discharge and urine whenever uterine cancer was suspected as early as 1854. And in 1860, he also described cancer cells present within the sputum. Over the next 60 years, no real progress was made in the field of cytopathology. And according to historian Bernard Naylor, the 1920s saw a virtual total rebirth in the field of exfoliative cytology. Before that, there were only isolated case reports and occasional case series that were regarded with a lot of skepticism by most pathologists. So the next critically important work in cytopathology was made by Leonard Dudgeon. In 1927, he described his wet film method for rapid intraoperative diagnosis that actually competed with the histologic frozen section. In 1928, we learned about George Papanicolaou's initial publication, and Earl Babish also published at the same time, both independently, came up with the idea that cervical cancer could be diagnosed with vaginal smears. There was a 20-ish year gap until George Papanicolaou, along with Herbert Trout, published their work, The Diagnostic Value of Vaginal Smears in Carcinoma of the Uterus. And of course, this was followed with the 1943 work, Diagnosis of Uterine Cancer by the Vaginal Smears, that had illustrations by Hashime Murayama. So let's talk a little bit about why there was such a long gap between the works of Beale and Dudgeon and then the works of Papanicolaou and Babish and Papanicolaou and Trout. So if we start by going back to looking at Lionel Beale, sorry, I lost my train of thought there. His textbooks, while promoting cancer cytopathology, also discussed alternate uses for the microscope, like crystal analysis, and a lot of other things that would now fall under the umbrella of clinical pathology. These alternate uses continue to progress. And in the late 19th century, a lot of this microscopy was actually performed by the clinician directly caring for the patient. By the early 20th century, however, these techniques had expanded to become part of the field of clinical pathology. A sampling of textbooks from the turn of the 20th century show the expansion of uses of the microscope far beyond what Beale had initially envisioned. For example, this work, Chemical and Microscopical Diagnosis, published in 1905 by Francis Carter Wood, described many uses for the microscope in an over 700-page text. But of those 700 pages, only 4 pages were devoted to cytopathology. So with Beale coming up with both cytopathology and clinical pathology, why did clinical pathology move forward and cytopathology remain stagnant? When Beale did his initial work on cytopathology, both histology and cytology were on equally shaky footing. However, in the latter half of the 19th century, with development of fixatives, embedding materials, stains, and microtomes, that led to the progression of histology over cytology. Most cytologists were viewing unstained preparations for much of the 19th century, and even Dudgeon's wet film method was not possible until Giemsa described the method in 1909 for protozoa preparation. To understand the reason for this lack of progress in cytopathology, we must first discuss some setbacks that occurred in the historical cytopathology literature. So initially at the time, there was a strong distrust of the microscope. Advances in cytopathology actually paradoxically led to a lack of progression in the field. At the time, the microscope was believed to be error-prone, and there was a discontinuous nature of work in cytopathology research. So if we start by thinking about, the first issue that we need to contend with was the distrust of the microscope. Alfred Steele in 1848 writes that the microscope is so difficult to use that only those who have already become experts can trust what they see, and it was believed that the microscope would never become part of daily practice. This idea is largely debunked by Francis Donaldson in his paper, The Practical Application of the Microscope to the Diagnosis of Cancer. In this paper, he notes that while the microscope can magnify things that were not previously visible, it cannot create, it cannot bring up new objects that were not there before. This issue could not have been the main cause, however, as it should have had an equal effect on the progression of histology. Paradoxically, advances in cytopathology actually prevented further progression in the field. In 1896, Berenberg published his technique of centrifuging serous fluids, fixing, sectioning, and staining the sediment. And by the 1920s, this cell block technique had become fairly standard practice in America. According to Naylor, this was a successful method, but it was essentially the same approach as the tissue pathologist. And so this led to a further lack of progression at the time. Early authors warned that microscopic cancer diagnosis was not an exact science, and use of the microscope was prone to errors. Dickinson, for example, in 1869, discusses how seemingly malignant cells can be found throughout the urinary tract, but these patients were then known to recover, which was an uncommon phenomenon of cancer at the time. In addition, the work of George Adams in 1951 discusses the discontinuous nature of work in cytopathology. There were various methods of processing specimens reported by different researchers in different countries without awareness of similar work being done elsewhere. Cytopathology would likely have been more prone to this problem than histopathology, as there were many more practitioners of histology at the time. While all 4 of these things that we've just discussed are true and did lead to a lack of progression in cytopathology, there was another phenomenon that was characteristic of the history of science in general that played a much more important role. The historian Thomas Kuhn, in his 1962 book, The Structure of Scientific Revolutions, writes that scientific advances occur through a series of paradigm shifts. And in order for cytopathology to progress, several paradigm shifts were required, including the acceptance of the idea of the uniqueness of cancer cells and a change in the definition of cancer. So in order to understand why this paradigm shift was necessary, let's first look at the prevailing theories at the time. Cell theory was established in the late 1830s by Matthias Schleiden and Theodor Schwann. In 1839, Johannes Müller proposed that cancers are composed of cells. However, most researchers and pathologists at the time did not believe that cells that made up of cancer did not believe that cancer cells were morphologically different from normal cells. The dogma of the time, which persisted well into the 20th century, was that cancer was defined by behavior, such as invasion and metastasis. Prior to Beal's work in 1854 advocating for the microscopic examination of cancer cells, there were very few who believed in the uniqueness of cancer cells. In 1843, Adolf Hanover published the first morphologic description of a cancer cell. And here we see listed other contemporaries who supported this idea before 1850. So while some pathology experts believed that the microscope could be useful for cancer research, very few believed that it could actually be useful for diagnosis. In the late 19th and early 20th centuries, it was difficult enough to get people to accept the validity of biopsy-based diagnosis. And accepting cytopathology-based diagnosis required additional changes in the prevailing theories of cancer. This included the idea that the magnification of tissue under the microscope does not alter reality. Cancer is not defined solely by behavior, and malignant behavior can be predicted by histologic appearance. In the case of biopsy, it was at least possible to see some elements of behavior with large groups of cancer cells. Cytology, however, only provided opportunity to examine single cells or small groups of cells without being able to see how they interact with one another. Some of the early adopters of the ideas of the uniqueness of cancer cells include Emil Kuss and Charles Cediot, who actually developed the first punch biopsy tool. They also performed the first 3 cancer biopsies and made diagnoses that were used to guide clinical management. Unfortunately, they did not continue with their work as they failed to understand its significance, and Kuss actually left the field of pathology and got involved in politics. Thus, many consider Karl Ruge, a German gynecologist, who we see here, to be the father of biopsy. He started performing biopsies in the early 1880s when he noticed that he could confirm the presence of cervical cancer in less than 50% of uterine cervices that were removed for cancer. In 1881, he said that he could make a histopathologic diagnosis of cancer from curettings. Unfortunately, most pathologists at the time disagreed with him as he could not see what was the definition of cancer, invasion and metastasis. Ruge ignored this criticism and trained his own followers, who then mostly became gynecologists. The belief that cancer cells were histologically unique was actually heresy at the time. Virchow and other prominent pathologists strongly opposed both the idea of biopsy for diagnosis as well as the concept of anaplasia, an idea introduced in the 1890s by David von Hensman, who we see here. Von Hensman believed that cancer was characterized by cells undergoing dedifferentiation and becoming anaplastic. And this was in contrast to the prevailing theory of the time that cancer arose from small groups of embryonal cells that persisted from birth. Unfortunately, von Hensman's theories were largely ignored and forgotten during his lifetime. However, he is now considered one of cancer biology's earliest luminaries. It was not until the introduction of the concept of carcinoma in situ in the 1930s that mainstream pathology discarded the notion that cancer was entirely defined by invasion and metastasis. This concept was difficult to accept, even in the cases of biopsy, where architecture and large clusters of cells could be visible. And it was even worse for cytopathology. Pathologists of the time were just not able to accept that cancer could be diagnosed from single cells. So with the acceptance of biopsy as a diagnostic method, along with the work of Dudgeon, Papanicolaou, and Babish in the late 1920s, why did cytopathology still not gain traction? One reason Dudgeon's work never took off is that he did not promote his own work. The historians Bruns and Spriggs note that Dudgeon died without a significant number of followers to continue his work. Another issue to contend with is by 1927, intraoperative diagnosis was considered the, quote, holy grail for cancer surgery. And in 1928, Dudgeon showed that cytopathology could be used for intraoperative diagnosis. Histologic and cytologic techniques competed for diagnostic supremacy, with the frozen section ultimately winning out. This was due to the fact that frozen sections utilize histology, which most hospital-based pathologists were already comfortable with, and they had negligible skills in cytopathology. Another reason was that the frozen section was being championed for political reasons. The Mayo Clinic, Johns Hopkins, the American Society for Clinical Pathology, and the American College of Surgeons were strongly pushing the frozen section in the 1920s and 1930s. In addition, widespread implementation of intraoperative frozen section diagnosis in the US was closely linked to the viability of hospital-based practice of pathology. Rare visionaries recognized that it did not have to be one or the other. This quote is from Bamforth, who was a trainee of Dudgeon, and he notes that the frozen section can reveal behavior, while cytology can show high-power nuclear detail, and the two methods should ideally be used in tandem. Even the work of Papanicolaou and Babish in the late 1920s, describing cytopathologic examination of vaginal smears, did not become mainstream until Papanicolaou and Trout's publications in the 1940s. This may be due in part to the obscure venues in which the works were produced, and also we heard earlier about Papanicolaou's unfortunate choice of publication with the eugenics movement. And his work was also full of transcription errors, so this likely led to a lack of any real widespread impact in the works. Another factor that prevented their work from taking off was Papanicolaou immediately returned to the study of the estrus cycle in animals and women, which is what he had been working on when he serendipitously discovered the presence of cervical cancer in cells in vaginal smears. He likely would not have continued with this work until he was encouraged by Joseph Hinsey. Here's a nice picture of Joseph Hinsey. He was appointed the anatomy department head at Cornell, where Papanicolaou was working, in 1939, and by 1941, he was the dean of medicine. Hinsey likely noted the expanding public campaigns stressing the importance of early cancer diagnosis, and multiple sources have credited him with encouraging the research that led to the development of the Pap test. By the time Papanicolaou and Trout's publications in the early 1940s, there was now abundant enthusiasm among both clinicians and the public for the work of cytopathologists. And this allowed for the rapid progression to the field that we know today. So in summary, while the field of cytopathology began with Lionel Beale in the 1850s, it did not take off for over 60 years. This was due in part to a lack of understanding of the power of microscopic diagnosis, along with the sporadic nature of research in cytopathology. More importantly, a shift in the definition of cancer as not being solely defined by invasion and metastasis was needed. And this occurred in the 1920s to 1930s, around the time of the publications of Dudgeon, Papanicolaou, and Babish. The field of cytopathology again did not progress, mainly due to a political preference for histology. And finally, the work of Papanicolaou and Trout in the 1940s allowed for the rapid advancement